Coleman is clinical professor of surgery and pediatrics at Michigan. As I think many of you know, she's now assuming the chief job of vascular surgery at Duke University. So we're going to welcome her to the South. Dr. Coleman is a lieutenant colonel in the U.S. Army Medical Corps, having served 3 deployments to forward combat areas for medical support. And we thank her for her service. She is a specialist in pediatric renal vascular hypertension. She's director of the center at Michigan for that. She is a specialist in aortic diseases and aortic coarctation. She is really an incredible cheerleader for trainees and young faculty of vascular surgery. We've seen her talk about wellness and other topics, and it's now our pleasure to welcome her to talk about visceral aneurysms. Dawn, thank you.
Thank you, Dr. Ross, and thank you to the Planning Committee for the opportunity to be here. I've been in the South now just a few times, really delighted to permanently relocate here very soon. But what I've been most impressed with, I think, so far in interfacing with your society is a firm commitment to our specialty and our workforce. I love what you're doing for the trainees. Thank you for that. I'm really excited to learn from all of you today and tomorrow across your presentations. Really excited to be here. My charge today was to speak on the management of visceral aneurysms and provide guidance from the most recent clinical practice guidelines from the SVS. I did choose to align myself with Duke University with this presentation, as we're just a few weeks away from that. I have no financial disclosures today, although I did sit on the writing committee for these guidelines. And I'll also propose that I'm a bit smitten with rare diseases. And so there are some features of visceral aneurysms and challenges that resonate with me as I care for children with rare disease. And so I think for that reason, I do have kind of a unique perspective that I can share with you today. And this is probably the most important slide to take away, and I'll show it to you up front. The guidelines that were published in 2020 provided 102 recommendations, and I'm going to go through every single one right now. And we qualified the recommendations, right, as strong or weak, high, moderate, low. It's very granular. There are only 9 recommendations in that whole document that have strong or high evidence. And so I'm going to say it now, I'm going to say it again when I close. We can do better. A general overview, one slide for visceral aneurysms. Approximately 5% of abdominal aneurysms are going to affect your visceral arteries. We tend to think of them as true versus pseudoaneurysms. Today I'll really concentrate on true aneurysms. And their etiology can be broad. And the etiology, I think, matters so much, and we often walk away from these cases not knowing the etiology. Most are attributed to a degenerative or atherosclerotic process in which histopathologic specimens of these aneurysms will yield a decrease in smooth muscle, disruption of elastic fibers, and deficiencies of arterial media. But we also see these aneurysms frequently associated with fibromuscular dysplasia, collagen vascular diseases, other inflammatory conditions, and rare inherited conditions, and then the pseudoaneurysms, as I referenced. And it is those less common etiologies, I think, that may portray a more aggressive natural history. And these are things to be thoughtful of when you're considering your patient's phenotype and how best to treat them. Celiac aneurysms historically have been described as symptomatic on presentation. They tend to portray fear in physicians when they're seeing and observing this pathology. And again, historically, they were associated with rupture and high mortality rates approaching up to 100%. Now, the more recent data would suggest that there may be an association with your rupture rate and size shown here, and that 5% of ruptures complicate aneurysms measuring 15 to 22 millimeters. That rupture rate obviously increases when your aneurysm grows 50 to 70% at greater than 3.2 centimeters in size. And in fairness, there's no absolute size criteria to direct the indication for treatment, but greater than 2 centimeters probably seems appropriate when you balance the risk of rupture without treatment at larger sizes and the morbidity and mortality that can be very low in elective cases when done at centers of excellence and by high-volume surgeons. We do know that rupture is rare during surveillance. You'll hear this with most of these aneurysms. Aneurysmal degeneration is rare in dissection-associated aneurysms and those of poststenotic dilation. Hepatic aneurysms are the second most common visceral aneurysm, and we find the majority of those being extrahepatic. We also find the natural history appears to be relatively benign. There's a relatively large series from the Mayo Clinic, and a third of their observed patients grew. Only a third, and there were absolutely no cases of rupture in those patients that were observed. And the majority of ruptures that we see across all series are reported at size greater than 2 centimeters. Non-atherosclerotic aneurysms, those associated with Wegener's granulomatosis, lupus, those seem more frequently to be multiple concurrent aneurysms in this territory and probably associated with a higher rupture risk. We also know that female gender may be a newly described risk factor for rupture in this particular territory. The recommendations for treatment for hepatic aneurysms essentially support treatment when patients have no significant comorbidities, treating true aneurysms at a size greater than 2 centimeters. And this, similarly to celiac aneurysmal disease, balances the significantly high morbidity and mortality that's associated with rupture, up to 30%, with the low morbidity and mortality that can follow elective repair. We find when these aneurysms rupture, they tend to rupture into the biliary tract or the peritoneal cavity. Splenic aneurysms, I think everybody appreciates, have a female predilection. And especially in young women, they are thought to have a particular tendency towards rupture. Pregnancy, we know to be associated with rupture. In fact, 20 to 50% of all ruptures are associated with pregnancy, and this tends to occur during the 3rd trimester and is associated with really devastating maternal and fetal mortality at 80 to 90% respectively. There's a large series also from the Mayo Clinic that looked at 217 patients, and the majority of those, 168, were surveyed for a mean of 75 months. These aneurysms had a mean size of 2.1 centimeters, but some were up to 5 centimeters, and they found that only 10% of these aneurysms grew, and that growth rate was about 0.6 millimeters per year. They also, similar to other territories, identified no cases of rupture during this surveillance period, and a similar series out of the Cleveland Clinic, published in 2011, really posted similar findings. We believe that asymptomatic aneurysms less than 3 centimeters can be safely observed. I'm sorry for that. Calcification has not been shown to be protective. And the natural history, as I referenced, is that of null to slow growth. It's important to think carefully about a specific subset of patients, again, those of childbearing potential, but we also know that those with portal hypertension associated with hepatic failure, underlying connective tissue disorders, these are risk factors that may relay a more aggressive natural history and more rapid growth. So treatment indications for splenic aneurysm are shown here with emergent intervention for rupture, treatment of non-ruptured cytoaneurysms of any size, treatment of non-ruptured true aneurysms for any size in women of childbearing age, otherwise non-ruptured true aneurysms sized greater than 3 centimeters with demonstrable increase in size or associated symptoms. But observation is now recommended for those true aneurysms less than 3 centimeters, especially in those patients with comorbidities and limited life expectancy. SMA aneurysms are uncommon. I'd sense most of us will see these associated with dissection, often accompanying aortic dissection. Atherosclerosis is an etiologic factor only in a quarter of these aneurysms. So again, in addition to dissection, we see them associated with inflammation. The majority of these patients do present with symptoms, and this is different from some of the other aneurysms. Their natural history also appears to be far less benign, in that up to half will demonstrate growth or rupture with surveillance, which will result in a much more increased risk of mortality when that happens. And so it is recommended to consider repair of all SMA aneurysms and pseudoaneurysms basically at the onset of diagnosis in an appropriately selected patient with discussion. Jejunal, ileal, and colic aneurysms are really, really rare. This etiology tends to be related to medial degeneration, most commonly. Infection, inflammation, other autoimmune diseases and connective tissue diseases are common in this cohort of patients. And multiple concurrent aneurysms occur 10% of the time. Colic artery aneurysms are a little different, and then they are almost consistently symptomatic. And rupture may complicate up to a third of those with jejunal or ileal aneurysms, up to 70% of those with colic aneurysms, resulting in GI bleeding. Mortality rates can approach 20 to 50% in these cases. And so this is really a strong recommendation supporting the elective intervention for true aneurysms of jejunal and iliac artery aneurysms measuring more than 2 centimeters. And for all colic aneurysms, really of any size. This is an image of a gastroepiploic aneurysm. These are typically associated with arterial dysplasia, segmental arterial medialysis, and also other inflammatory conditions. Gastric aneurysms are 10 times more common than gastroepiploic aneurysms, and the majority will present ruptured. Most of those patients, when they present ruptured, have demonstrated few antecedent symptoms. They tend to bleed more into the GI tract than into the peritoneum, and mortality rates are quite high, and so there is strong recommendations to treat these aneurysms at any size. When we look at pancreaticoduodenal and GDA aneurysms, these can often be associated with celiac artery stenosis and occlusion. Ruptures also have similarly been identified at very small sizes, less than 10 millimeters, again, more frequently into the GI tract than the peritoneal cavity. And interestingly, in this particular vascular territory, male gender may be a risk factor for rupture. I wanted to poll the audience just before I get into the rest of the 92 recommendations we still have to cover. And present a case, and if you're a trainee, feel free to raise your hand. You don't have to, but I'm really looking at all of the faculty here. This 34-year-old woman who's got 2-drug, well-controlled hypertension presents to you with this CT scan, supporting bilateral, right greater than left, renal artery aneurysm affecting predictably that terminal main renal artery. And the size of max diameter on the right is 2.2 centimeters. You can see a really nice angiogram supporting multifocal fibromuscular dysplasia, or that string of beads. I want you to raise your hand if you would offer this patient treatment. Would anybody fix this 2.2 centimeter aneurysm on the right? Put your hand up.
Come on, Guillermo.
Dr. Jordan, really, just you? Anybody else?
I would.
Hands up, anybody? All right, so of those that had your hand up that you would fix the right side, would any of you fix both? Would anybody fix the FMD? Yes. And put your hands up if you'd observe the patient. Oh, well, this is really poor participation. I'm positive that we would do better both in Michigan and in Durham. Let's try that one more time. How many people would fix the right renal artery aneurysm? Okay. How many people would just observe for right now? Okay, well, that's a little better, I guess. Renal aneurysms, I think I'm going to get back to that slide, I promise. Renal aneurysms are mainly saccular. They're almost always extrarenal, and we know they occur at bifurcations. They also are strongly associated with FMD. I see a lot of FMD patients, and so I really like this pathology. Like many of the other aneurysms we've talked about, they have a very benign natural history with slow to null growth, and rupture is extremely rare, although associated with pregnancy, as we see with splenic aneurysms. You also can see them at times associated with arteriovenous fistulas, and interestingly, about 2/3 will have a form of renovascular hypertension. I I said that we can do better, and we have to do better by thinking about how we study these rare diseases, which often the data comes from single institution series. I trained with Jim Stanley. He was a formative mentor to me. And there's a way Dr. Jim Stanley approached all of his patients with pediatric disease and renal aneurysms, and it really worked well for him. And he published really great results. And I'll be very honest, I'm not confident that I'll ever reproduce those results. And I'm not sure how relevant those series are when we think about how the rest of the world should be treating patients with this disease process. It truly biases the data that gets circulated, but right now, or up until now, it's the best we have. The Vascular Low Frequency Disease Consortium has been a really helpful way to at least utilize retrospective data from multi-institutions to help us learn perhaps stronger conclusions. And ideally, this would carry forward to a more prospective form of study. But this was a really seminal project that was published, I think in 2018, I can't quite recall. But we looked at over 865 renal aneurysms that covered 760 patients across 16 institutions, of which we found 2/3 to be asymptomatic. Elective repair was performed in 213 patients, usually for a size that was greater than 2 or for those with symptoms. But of the remaining 547 patients, they were observed. In the operative cohort, major complications occurred 10% of the time. And of those that were observed, we found that there were no cases of rupture. 88 aneurysms that were more than 2 centimeters were followed for about 30 months. And there were 7 renal artery aneurysms that were more than 3 centimeters that were followed. Again, no ruptures, no acute complications, and there was serial imaging performed in the majority of these cases. Of the patients that ruptured in the series, there were 3, and they all had transferred from other hospitals, meaning they weren't in a window for surveillance. They all underwent emergency repair, and none of those patients died. Of the patients that were followed, we found a mean growth rate that was only 0.086 millimeters per year, and we found no difference in growth between those with and without calcification. And so the conclusion was from this study was that aneurysms less than 3 centimeters rarely rupture, even when size 2 to 3 centimeters and not calcified. The growth rate's really slow. We also found that hypertension could be cured or improved in patients who had associated renal artery aneurysms, yielding really what was a controversial set of recommendations with a weak strength of recommendation to defer elective repair to those aneurysms greater than 3 centimeters. And so going back to this patient, this is my patient, and I did choose to treat her right renal artery because she was 34 years old and she had a likely chance of becoming pregnant. She also had hypertension, but I only chose to fix the right side. And I did that through a subcostal approach, excising the aneurysm, and then performing a direct angioplastic repair. But I also chose to dilate her renal artery to address her intravascular webs, and this was her completion study. The final comment I just want to make is that there is some interesting data that suggests a coexistence between renal artery aneurysms and intracranial aneurysms, again in a biased cohort of patients with underlying female gender, which is associated with a higher incidence of fibromuscular dysplasia. So we looked at 84 women with renal artery aneurysm and found that about 20% of them had FMD, 2/3 of them had hypertension, and 1/3 of them had a head and neck image that we could reference. And we found a 10.7% incidence of intracranial aneurysm, which exceeds the incidence in the general population of 2.8%. And this is likely an underestimate since 2/3 of our women didn't have imaging of their head and neck. But I think it's important to think about because we also found that those patients with head and neck aneurysm, they had a significantly more likely incidence of having multiple renal aneurysms and larger aneurysms than those without. And so there are a lot of guidelines. They're made with weak evidence. They're all shown here. There's a really nice table that you can see or figure in the website online. But in summary, I just want to propose that the guidelines have really suggested a few things. The first is that we're seeing these aneurysms diagnosed with increasing frequency as we use more cross-sectional imaging, and they're incidental findings. My bias is that phenotype matters when you're thinking about your patients. Not every aneurysm is the same. It's important to screen for concurrent aneurysms, and not all true aneurysms now need to be treated at 2 centimeters, as I was taught as a fellow. In general, endovascular repair is first line when anatomically feasible, and I didn't feel the need to get into the nitty-gritty of that today. I hope you don't mind. I wanted to thank the Georgia Vascular Society for the opportunity to be here very much, and just remind us all that we can do better. And I think we've heard that from all of the speakers so far this morning, and I look forward to doing better with all of you as we move forward as a specialty. Thank you.